Good morning. My topic is for today is basic concepts of occlusion. As an introduction, I would like to explain the term static and dynamic aspects of occlusion. So what do you mean by static occlusion? It is the form, alignment and articulation of teeth within and between the arches and relationship of teeth to their supporting structures. This is known as static part of the occlusion. Now let us talk about definition of dynamic occlusion. So dynamic occlusion basically means the function of the stomatognathing system as a whole, which comprises of teeth, supporting structures, TMJ, neuromuscular, and nutritive systems. So all these systems combine together and form the stomatognathing system. So there are some terminologies that has to be learned before talking about occlusion. That is ideal occlusion, physiologic occlusion, balance occlusion, functional occlusion, and traumatic occlusion. So what is an ideal occlusion? So ideal occlusion is a preconceived theoretical concept of occlusion, which involves occlusive structures and functional relationship that include idealized principle and characteristics that an occlusion should be having. Next is the physiologic occlusion. So any occlusion that deviates from ideal and yet remains well adapted to the particular environment is known as physiological occlusion. Next comes a balance occlusion. So in balance occlusion, equal contacts are maintained throughout the entire arch during all excursive movements of the mandible. Next is the functional occlusion. That one type of occlusion which provides the highest efficiency during all excursive mandibular movement is called as functional occlusion. Finally comes traumatic occlusion, which is usually an abnormal type of occlusal relationship which is capable of producing injury to the periodontium and the supporting structures around the tooth. Now, on a tooth, there are various types of cusps. So first is centric holding cusps. So they are the buccal cusps of mandibular posterior teeth, palatal cusp of maxillary posterior teeth. These cusps include into the central fossae and marginal ridges of the opposing teeth. These cusps are otherwise known as a stem cusp. So next comes the non-supporting cusp. So they are maxillary buccal and mandibular lingual cusps. They basically contacts and guides the mandible during lateral excursion and during process of mastication. Also protrusive movements. So how is the teeth arranged in human? So human dentition exhibit two types of tooth arrangement while they are in occlusion. They are cusp fossa occlusion and cusp embrasure occlusion. So in cusp fossa occlusion, the stem cusp of one tooth occludes with the single fossa of an opposing tooth. So there are upper stem cusp and lower stem cusp. So upper stem cusp, they fit into all except the mesial fossa of the lower teeth, and the lower stem cusp fit into all the upper fossa except the distal ones of the bicuspids. So next comes the cusp embrasure occlusion. In this type of teeth arrangement, each tooth is to be occluded with the two opposing teeth and their embrasures. So there are few imaginary curves that are present in the human dentition that are important in the field of orthodontics. So what are these curves? These curves are the curve of P, curve of Wilson, and the curve of Monson. So let us define the curve of P first. So what is a curve of P? So curve of P, it relates to the anterior posterior curvature of the occlusal surface, which begins at the tip of the lower cuspid and it follows the cuspal tips of the bicuspids and the molars, and it continues as an arc through the mandibular condyles, through each of the condyles. So this curve, when it is usually extended, when it is imaginary extended, it forms a circle of about 4 inches in diameter. So next comes the curve of Wilson. So curve of Wilson is a mediolateral curve that contacts the buccal and lingual cusp tips of the mandibular buccal teeth. So it usually results due to an inward inclination of the lower posterior teeth. So all the lower posterior teeth, there is a slight inward inclination. So in this inclination, when viewed from the anterior aspects, causes a curvature in the mediolateral direction. So hence the term medial lateral curve for curve of Wilson. So third curve is the curve of Monson. So it is usually a combination of both the curve of P and the curve of Wilson. So it is usually obtained by extending the curve of P and the curve of Wilson to all the cusps and incisal edges. So finally, we'll be getting the curve of Monson. So in diagram A, we can see the curve of P extending anterior posteriorly. In diagram B, we can visualize the curve of Wilson, which is a mediolateral curve. So the direction of the arrowhead, there is a small curvature in both the curves. So in the picture B, we can see there is an inward inclination of the mandibular posterior teeth. So this creates a slight curvature when viewed from the frontal aspect. And in picture A, we can see the curve of P extending from the incisal edges, cuspal tips of premolars through the cuspal tips of molars. And when that curve is extended, goes through, passes through the mandibular condyles. And approximately, we'll be getting a circle of diameter about 4 inches. So next terminologies that we should be familiarized with is centric relation and centric occlusion. What is centric relation? So centric relation is the relationship of the mandible to the maxilla when the mandibular condyles are in the most superior and retruded position in the glenoid fossa with the articular disc properly interposed in between the condyles. So centric relation has another term. It is also known as a ligamentous position or terminal hinge position. So at this centric relationship, we can see that both the condyles are simultaneously seated in the most superior position in the glenoid fossa. So next terminology is centric occlusion. So centric occlusion is that portion of the condyle when the teeth are in maximal intercuspation. So few researches which are done previously in the field of orthodontics shows that centric occlusion is found to be around 1 to 2 millimeter ahead of centric relationship in majority of the population. So next terminologies are about centric contacts. So what are centric contacts? They are areas of teeth that contact the opposing teeth, which can be primarily classified as posterior centric contacts and anterior centric contacts. The posterior centric contacts, they are basically consisting of facial and lingual ranges of contacts. In the facial range of posterior contacts, mandibular facial cusp lips contacts the central fossa and mesial marginal ridges of opposing teeth. So in the lingual range of contacts, it involves maxillary lingual cusp tips contacting the central fossa and distal marginal ridges of opposing mandibular teeth. So while talking about anterior centric contacts, they are usually in line with the facial range of posterior centric contacts. So previously we have talked about centric occlusion. So let us talk about eccentric occlusion. So what does eccentric occlusion means? It refers to the contact of teeth that occurs during the movement of mandible. They are basically classified into two types. That is functional occlusion. That is in functional occlusion, the tooth contacts occur in the segment of the arch towards which the mandible moves. So functional occlusion is usually classified or divided into two types. That is, first one is lateral functional occlusion, in which the tooth contacts occur on canines and the posterior on side towards which there is mandibular movement. First is lateral functional occlusion. Second will be canine guidal occlusion. Third will be group lateral occlusion. So in canine guidal occlusion, on the side at which the mandibular moves, there will be cuspal tip contacts of the canines of the working side. So in group lateral occlusion, when the mandible moves towards one side, the all the teeth, the group of teeth in that side, there will be contact on one side, and the other group of teeth on the non-working side, there won't be any contacts. So second one is protrusive functional occlusion. That contains non-functional occlusion in which the tooth contacts that occur in the segment away from which the mandible moves. So in protrusive functional occlusion, that is it is mainly refers to the incisal edges of when the mandible moves forward. The normally the incisal edges will be that is the lower incisal edges of the lower incisor will be in the occlusal fossa of the maxillary incisors. So that will be the normal case. So when there is a protrusive functional occlusion, what happens is from the normal incisor upper and lower incisor position, the mandible moves forward and the lower incisor glides along the lingual surface of the upper incisor, and it comes up till an edge-to-edge incisor relationship. So during that incisor relationship, there will be contact of the upper and lower incisor, and there will be no contact on all the other posterior teeth will be disoccluded, or there won't be any contacts. So these are the factors coming under functional occlusion. So functional occlusion is the normally seen occlusion that is preferred, and non-functional occlusion, it is slightly deranged type of occlusion. That is the tooth contacts that is occur in the opposite way, that is segment away from which the mandible moves. Now let us come talk about the term disclusion. So disclusion is used to describe disocclusion or separation of the non-functional posterior teeth during eccentric movements. They are brought about by condylar and incisal guidance. So what is condylar guidance? In case of condylar guidance, in case of protrusive movements, both the condyles, that is both the mandibular condyles, they undergo translation or downward movement along the slope of the articular eminence. That is on the joint area, there is an articular eminence. So during protrusive movements, both the condyle, it undergoes translatory movement, which leads to disocclusion of the posterior teeth. During that time, the anterior teeth, there will be some occlusion. In posterior teeth, there will be a disocclusion. In case of lateral movements, condyle on the working side rotates on the axis. That is, there will be one working side condyle and one non-working side condyle. So working side condyle will be undergoing a rotatory movement around its axis, while condyle on the non-working side, there will be slight translatory movement, that is forward movement. So what happens? That side there will be a disocclusion. So next is the incisor guidance. So what happens in incisor guidance? There will be sliding of the mandibular incisors from the area of centric contacts. So what is the area of centric contacts? That is the lower incisor will be occluding on the singular table of the maxillary incisors. So from that area, the lower incisor will be sliding forward to and will be tracking downwards and forwards till it reaches an edge-to-edge relationship. That is lower incisor will be in an edge-to-edge relationship to the upper incisor. This leads to a posterior disocclusion. So finally, we have to talk about Andrews' 6 keys to normal occlusion. So Andrews, during the 1970s, he has did some study on 120 models of patient who had an ideal occlusion. That is a patients who have not undergone any type of orthodontic movements. These patients had an ideal occlusion. That is certain angulation and proper cusp to fossa relationship of all the teeth. So after examining these 120 models of the patients, he has concluded certain things, and he has formulated 6 keys that lead to a normal occlusion of anterior and posterior teeth. So what are the 6 keys that we are talking about today? So 6 keys are, first one is molar interarch relationship, mesolingual crown angulation, labiolingual crown inclination, absence of rotation, tight contacts, and the curve of speed. So first coming to molar interarch relationship. What does molar interarch relationship means? That is the mesiobuccal cusp of first molar should occur with the buccal group of mandibular first molar. Then there is an ideal occlusion achieved. Also, the mesiolingual cusp of maxillary first molar should occlude with the central fossa of the mandibular first molar. These are the two types of points that has to be noted in molar interarch relationship. So next is a mesiolingual crown angulation. So there is a line that is extending from the cervical area, that is the deepest point of the cervical aspect of the crown, towards the incisal edges or the cuspal tip of maxillary anterior and posterior tooth. So this is the facial axis of the clinical crown or FACs. So certain anterior and posterior teeth have a certain angulation, that's crown angulation, that has to be achieved in order for an ideal occlusion. The third one is a labiolingual crown inclination. So certain tooth will be having a labiolingual inclination of the crown. That is maxillary anterior, that is the central and lateral incisor will be having a positive torque of the crown. That is the positive angulation of the crown, and maxillary lower incisor will be having a slight negative crown angulation, inclination. So if these are achieved, then there is a normal occlusion present for that particular dentation. The fourth one is absence of rotation. So what is absence of rotation? So all the tooth should be in ideal position without any rotation. If it deviates from an ideal occlusion relation, there will be some form of rotation present. That is maxillary incisor will be occupying less space if it is rotated, and maxillary or mandibular posterior teeth, when these teeth are rotated, they will be occupying more space. So all the rotated teeth has to be brought into ideal positions according to Andrews. The next key is presence of tight contacts. So there should be no spacing present between adjacent teeth according to the Andrews. So that creates a tight contact which leads to normal occlusion. The final keys for Andrews 6 keys of normal occlusion will be curve of P. As I have already defined a curve of P previously, it is an anterior posterior curve. So the curve of P as described by the Andrews should not, it should be flat. That is, the occlusal plane should be flat. And if this curve of P, if at all it is present, it should not exceed more than 1.5 mm in the mandibular arch. If it exceeds 1.5 mm, that occlusion is not termed as an ideal normal occlusion. So in conclusion, I would like to say that by understanding various concepts of occlusion, we will be able to formulate an ideal treatment plan for each individual. That could bring about a final outcome where there is no derangement of jaw movement. There will be a better cuspal and incisal relationship and improved aesthetics for the individual. Thank you.